morning. My name is Zarine Patel. I am a clinical health psychology PhD student at Yeshiva University. I'm also a member of the HS Treatment Center at Montefiore Medical Center. My understanding is I'm the last person. I'm the person between you and your break. But I think this is a really important topic, and especially after listening to the last couple of presentations. So I'll be presenting on the relationship between pain, depression, and quality of life in patients with hidradenitis suppurativa. So I do not have any financial disclosures to report, but I do want to note that the data that I'm presenting on today are from a AbbVie-sponsored protocol on the impact of HS on quality of life. So as we've heard this morning, HS has a profound impact on quality of life compared to other skin conditions. And the Dermatology Life Quality Index, the DLQI, is a widely used measure that captures the impact of living with a skin condition. It's been used in over 40 different skin conditions, so it allows us to compare the impact of HS with other conditions. And the figure you see on the right is from a paper published by Dr. Alavi, who we just heard from. And what it's showing is that the DLQI scores for HS surpass those of other skin conditions. So our group at Montefiore recently completed a review of pain, psychological comorbidities, including depression and anxiety, and impaired quality of life in HS. And we felt it was very important to address these factors before developing comprehensive and multidisciplinary treatments for HS. So the figure you see here is something we proposed. So based on our review, we found that patients with HS had high rates of pain, disability, depression, anxiety, and impaired quality of life. And what we proposed based on this research and as well as what we know theoretically about these domains is that each of these factors are highly interrelated and they're multidirectional effects. And for the purpose of this talk, I wanted to focus on pain, quality of life, and depression for a number of reasons. So pain and depression have both been identified as important factors in impaired quality of life. Pain is also something that on a weekly basis, I talk to HS patients about. It's something that's coming up in a lot of their clinical visits. It's also been identified as an important patient-centered outcome. And we know that in chronic pain, depression is a frequent comorbidity. So the data that I'm presenting on is taken from an ongoing study on the impact of HS on quality of life. So this is a longitudinal study, but I'm presenting on baseline data of 194 patients. These are patients who completed 3 different measures: a quality of life measure, so the DLQI, a measure of depression, the Beck Depression Inventory, which looks at symptoms of depression, as well as the RAND 36-item health survey, the SF36, which is looking at health and well-being across 8 domains, and I specifically looked at the bodily pain and pain interference subscale. And for the data analysis, I ran ANOVAs and Pearson R correlations to look at relationships between these three factors. So in terms of the demographics of what we found, the sample was predominantly female, with 74 patients being female. We also found that almost half, 48.5%, of the patients were Black or African American. 28% of patients identified as Hispanic or Latino. And the average age at the time that patients came in for this first baseline assessment was 38 years old. I think the 8 got left out there, was 38 years old, keeping in mind that in order to be eligible for the study, patients had to be 18 or older. In terms of the Hurley breakdown, 40% of patients were Hurley stage 3, which we attributed to being a tertiary care center at Montefiore specializing in treating HS patients. So in terms of looking at DLQI overall, on average, patients had a score of 15.2, which corresponds to a very large effect or impact on quality of life. And then when we looked at this across stages, we found a significant difference between stage 1 and stage 2 patients, as well as stage 1 and stage 3 patients, with stage 2 and stage 3 patients having DLQI scores that correspond to a very large effect. We looked at SF scores, which met this specific subscale which measures bodily pain and pain interference. On average, patients had a score of 46, which corresponds to a below average health status related to bodily pain and pain interference. So greater bodily pain, greater pain interference. And then again, when we looked at this across stages, we found a significant difference between stage 1 and stage 2 disease and stage 1 and stage 3 disease, with patients with stage 2 and stage 3 disease having below average health status on this measure. And then when we looked at depression, overall, on average, patients had a score of 13.1, which is at the upper threshold for minimal depression, for minimal depression. And then when we looked across the stages, again, there was a significant difference between stage 1 and stage 2 disease and stage 1 and stage 3 disease, with patients with greater disease, stage 2 and 3, having scores that correspond to being in the mild depression range. So next we looked at correlations between these different factors. So starting with the DLQI, and I apologize, I think got cut off, but what's on the x-axis here is the pain interference, bodily pain and pain interference subscale. So when we're looking at the relationship between quality of life and pain, what we found is higher scores on the DLQI, which means greater impact on quality of life, corresponded with lower SF-36 scale subscores, which indicate below average health status with bodily pain and pain interference. And this was a strong association or correlation. Next, we looked at the relationship between quality of life and symptoms of depression on the Beck Depression Inventory. And what we found here was higher levels of higher scores on the DLQI, so greater impact on quality of life, was strongly associated with higher scores on the BDI, which corresponds to greater symptoms of depression. And then finally, when we were looking at the relationship between pain and depression, lower scores on the SF-36 corresponding to higher symptoms of pain had a strong relationship with higher scores on the BDI, which indicate higher symptoms of depression. So overall, we saw that patients in our sample, so of 194 patients, they had high DLQI scores, minimal to mild symptoms of depression on average, and high bodily pain and pain interference. And so the takeaway message we felt here was these are central to the patient experience of HS. They should be thought about in the context of standard clinical care, but also in terms of the development of comprehensive and multidisciplinary treatments of HS. And then just going back to this figure, this helps us to validate the relationships between some of these major factors that are important to quality of life in HS, and in particular pain and depression here. And I just wanted to thank the HS Foundation for inviting me here today, as well as my mentors, two of whom are in the audience, Dr. Cohen and Dr. Lowe's, and the entire HS Treatment Center at Montefiore.